And we are live.
Hi, everyone. Good afternoon, and thank you for joining our panel, Understanding and Addressing Disparities in Early Age Onset Colorectal Cancer. My name is Candace Henley, and I am soon to be 18 colorectal cancer survivor diagnosed at age 35. My diagnosis is one that we don't often hear about because it wasn't so much about my journey through colorectal cancer as it was about the financial toxicity of colorectal cancer, which is something that we don't discuss enough. And at the time, I didn't realize that what I was experiencing going through my cancer journey was a healthcare inequity. I was misdiagnosed for 6 months. My diagnosis was considered to be an OBGYN issue. And so me not knowing and understanding the magnitude of this, I said, okay, because I felt like, yeah, I did have these issues. So I wind up having my uterus and my ovaries removed, all to find out that that was not the issue at all. And to come back to find out 6 months later that my issue was colorectal cancer related. Once I was in the emergency room on my third trip to the emergency room, I wind up having a fecal occult blood test, which is where they found blood in my stool. And at that time, I didn't understand the language because they were speaking in medical terms, and I just didn't understand what they're saying, especially when they were saying that you had blood in your stool, and I knew that I had a hysterectomy. So once they did the fecal occult blood test and they found blood in my stool, I had to have an emergency colonoscopy. And that is where they found a grapefruit-sized tumor on the right side of my colon, and I never left the hospital. Unfortunately, me not leaving the hospital also meant that I was not able to return to work and able to take care of my family and wind up losing everything and becoming homeless with 5 children. That experience also left me devastated emotionally, mentally, and spiritually to the point where I was suicidal and attempted to take my own life because at that time, no one offered me psychosocial support. Fortunately, I was not successful. And I was able to get myself together with the help of a very special and kind nurse who told me that my children needed to know me. I became an advocate to learn everything I could about colorectal cancer because no one should have had to have gone through what I experienced and not know why. At the time, I didn't know that it was my father and 2 aunts who were diagnosed post-autopsy with colorectal cancer. They never knew. They died of other causes. As a result of that information, it happened 11 years after my cancer diagnosis that my aunt didn't share. And so we have a tagline that called it the saying, family secrets kill families. What my aunt didn't share with me almost killed me. My journey led me to start the Blue Hat Foundation, which is a nonprofit that raises awareness of colorectal cancer in minority and medically underserved communities. African Americans and people of African descent have a 20% higher incidence of colorectal cancer and 40% more likely to die from colorectal cancer. Inequities, unfortunately, contribute to many factors of an increase in risk of early detection and early onset colorectal cancer in minority communities. We have to do better in our healthcare system. We have to help our healthcare system improve inequity and remove racism from our healthcare system so that those people, so those of us, people of color, don't have to face structural, institutional, and interpersonal racism that prevents us from being seen as people and treated as if we are people. No one should have to face healthcare inequities, facing any type of healthcare issue, crisis, cancer, medical crisis, period. So I thank you so much today for tuning in to this very important discussion. And I would now like to turn it over to Dr. Elena Stoffel, who is the director of the University of Michigan Cancer Genetics Clinic and the assistant professor of internal medicine at the University of Michigan. And she will be presenting on disparities in early age colorectal cancer. And she will be joined by Dr. Sonia Kupfer, who is the associate professor of medicine and the director of gastrointestinal cancer risk and prevention clinic, co-director of comprehensive cancer risk and prevention clinic at the University of Chicago. So I will turn it over to you, Dr. Elena Stoffel.
Thank you very much, Candace. It's such a pleasure to be joining you today as part of this really important session, which I think will highlight, kind of wrap together what you all have been hearing about over the past 2 days of this conference, and kind of put this into a perspective of how this affects the work that medical professionals do, but also how, as patients, the information you provide is going to be critical in helping all of us advance the field and take better care of patients and families. Erin, could I have the first slide up, please? So, as Candace mentioned, I am the director of the Cancer Genetics Clinic at the University of Michigan, and I've had the pleasure of working very closely with Dr. Sonia Kupfer, who is joining us for this session as well, because we have been the focus of our careers have been early diagnosis and management of individuals and families that have a genetic predisposition to cancer. So, next slide, please. So, as gastroenterologists, and as most physicians do, when we think about an individual's risk for colorectal cancer, we consider the individual's age, their family history of cancer, which until recently had really been limited to whether any first degree relatives have had colorectal cancer, and then the person's personal history. Have they had colon polyps in the past, or do they have diagnoses associated with increased risk for colon cancer, like inflammatory bowel disease? But what we're learning now is that the picture of assessing an individual's risk for colorectal cancer is much more complicated than this. There are genetic factors that Dr. Kupfer and I study in depth to try to that influence an individual's risk for cancer. But we're also learning that there are likely a variety of environmental factors which also play a role in the individual's risk. And the key for what the medical field is working on right now is how do differences in genetics and environment impact individuals' risks for developing colorectal cancer at a young age. Next slide, please. I keep mentioning genetics because Dr. Kupfer and I, after all, this is what we do, and we know now that approximately 1 out of every 10 patients with colorectal cancer has an inherited gene change in a gene that's associated with a predisposition to cancer, and that rate is a lot higher than we thought it was. But next slide, please. In young people, the rate is actually higher still. And our group at University of Michigan had presented our findings in evaluating 430 young people with colon cancer who were diagnosed between the ages of 16 and 49. Next slide, please. And in looking at the characteristics of these patients, what was really striking was that only about 1 out of every 4 reported having a family member with colon cancer. Unfortunately, most of these cancer diagnoses were at advanced stages, and most of the cancers were left sided. Next slide. But in this population of young people with colon cancer, 1 in 5 had genetic factors associated with cancer risk. So this was twice as common in young people as an individual was diagnosed at older ages. Next slide, please. And our colleagues at Ohio State University found exactly the same thing in their study of patients diagnosed in the state of Ohio. In doing genetic testing with a 25 gene panel, they found that 16% of young people with colon cancer had a genetic diagnosis. And importantly, 1 out of every 3 of the individuals who had a gene change would not have met criteria for genetic testing for that condition. So, as you've heard at the meeting, the most common diagnosis in young people with colorectal cancer who have a gene change is Lynch syndrome. Next slide, please. And Lynch syndrome is responsible for approximately 3% of all colorectal cancers overall, but it's about 8 to 10% of young colorectal cancers. Lynch syndrome is typically characterized by young age at cancer diagnosis, the presence of multiple colon cancers, or sometimes people can develop colon cancers even after they've been treated for a previous colon cancer. And other cancer types are also more common in Lynch syndrome, including gynecologic cancers like uterine cancer and ovarian cancer, stomach cancers, and small bowel tumors. Germline alterations in the DNA mismatch repair genes are the most common, are commonly found in individuals with Lynch syndrome. And what is new information is that the population prevalence of Lynch syndrome is about 1 in every 300 people. So when I tell both physicians and patients about this, it's really very striking that when you look at, say, a stadium on a given day, um, 1 out of every 300 people in that stadium will have Lynch syndrome, and most people don't know about it yet. Next slide, please. So, how do we diagnose Lynch syndrome? I think that this is where um, we can all do a better job at identifying who which people meet criteria for genetic testing. And as Candace so eloquently mentioned, family history is so important, and knowing about the cancers in a patient's family can help them bring this to the attention of their doctors. But their doctors also have to talk to patients and ask them about their family history, not only of colorectal cancer, but of other cancer types. And then finally, we have to make it easier for people who have a family history of cancer to get the care they need. And if that means genetic testing, it could be genetic testing. But also, you could argue that a lot of these same factors that influence whether or not someone gets genetic testing also influence whether they will get a colonoscopy or get colon cancer screening. Next slide, please. So this is a really important paper that Sonia Kupfer and her colleagues put together, looking at what is the prevalence of this common Lynch syndrome condition in African American families with colorectal cancer. And what was really striking was that back in 2015, when Dr. Kupfer's team did this study, across 13 centers that specialize in taking care of families with Lynch syndrome, she was only able to identify 51 African American families who had a confirmed genetic diagnosis. And this is really important because, as Candace was alluding to, if we don't ask and if we don't talk about family histories of colon cancer, we're going to miss opportunities to prevent cancers. And in Lynch, colon cancers are preventable through early screening and other interventions. Next slide, please. So, as Candace mentioned, colorectal cancer incidence and mortality are highest in individuals of non-Hispanic Black ancestry. Racial disparities in older onset colon cancer are most prominently seen in individuals with advanced stage disease. And people have tried to explain this in the past by saying, well, the uptake of colorectal cancer screening is lower in African Americans. There could be differences in cancer treatment in African Americans. But the reality is that the incidence of colon cancer under the age of 50 is at least twofold higher among non-Hispanic Black individuals. Next slide, please. And so when we're talking about young cancer diagnoses, like as you heard in Candace's case, cancer diagnoses at age 35, those cancers are not necessarily because screening, average risk screening is lower in African Americans, and it's not necessarily because of differences in cancer treatment. Candace's diagnosis was at a young age, and we're still trying to figure out why individuals like Candace are diagnosed with colorectal cancers significantly earlier than we used to see even just a few years ago. Next slide. One of the things that we did was we actually wanted to look at in young people with colorectal cancer, do we still see the same racial disparities that we see in survival among individuals based on their race and ethnicity? And we analyzed SEER data to look at specifically survival in young people. Next slide, please. And these curves, there's a lot of busy information on here, but to summarize, the blue curve demonstrates the survival among young African Americans with colorectal cancer, whereas the green one is Hispanic individuals, and the red one is non-Hispanic white individuals. And as you can see, survival for young people, among young people with colorectal cancer, survival for African Americans is lower at every stage, but the biggest differences are among individuals diagnosed with stage 2 disease. And this is very important because in stage 2 colorectal cancers are the colorectal cancers for which our current chemotherapy um, does not seem to have a significant increase in prolonging survival. So the question here is what is different about stage 2 colorectal cancers in young people, and particularly what is different in stage 2 colorectal cancers in young people by race. Next slide, please. What we found was that among young people with early stage colon cancer, young Black patients are 60% more likely to die of their cancer than young white individuals. Is this because of differences in cancer treatment? Is it perhaps that young white patients than young Black patients? Is it that there's a difference in tumor biology? Are tumors in young people more aggressive than tumors in older people? And does chemotherapy treatment for stage 2 colon cancers make a difference in young people, whereas it doesn't in older people? And what do we know about the biology of tumors that develop in young people? And how do these tumors respond to our conventional treatments? Next slide, please. So you've seen this slide several times. This is Dr. Siegel's slide looking at the incidence, the increased incidence in colorectal cancer over time among young individuals as compared to the declining incidence of colorectal cancer among older individuals. Next slide, please. This is a really compelling graph that from Caitlin Murphy and colleagues that demonstrated that the colorectal cancer risk among people who were born after 1960 has continued to go up for reasons that we don't understand. And the colorectal cancer risk for millennials is approximately 4 times higher than that of their grandparents. And we don't know why this is going on. Next slide, please. This slide basically shows, again, in purple, the incidence of early onset colorectal cancer by race ethnicity. African Americans are seen in purple with the highest risk, and Asians are seen in the solid green, and non-Hispanic white individuals are in the light green. As you can see, the rates of colorectal cancer among African Americans has always been higher, but the rates among young white individuals are approaching the same level. Next slide, please. Now, this is a map from Sonia Kupfer's paper that looks at the incidence rates in colorectal cancer of all races among individuals under the age of 50. And what we see here is that this is not random. There are the areas that are shaded darker. As you can see in the South, the incidence of colorectal cancer among young people is much, much higher than it is in places like the Northeast. And when we want to talk about why does this make a difference, are there things playing a role here that we haven't been able to measure properly that we're not taking into account when we're doing risk stratification? Next slide, please. So this is a figure that Andriana Holawati recently published in a review that talks about what are the things that we're not measuring. The smallest circle here is biology and genetics, and that's where we've spent a lot of our focus. But as Candace so eloquently mentioned, there are other things playing a role here. There are environmental factors. There are the degree, the health of communities, what is going on in families, what is the access to good food, what is the access to good treatments, what is the access to regular health care and to doctors and healthcare providers who believe you when you report the symptoms that you're having. And I think that this is where we need to focus a lot of our work in order to be able to identify the causes for health disparities and to reverse these. Next slide, please. So when we talk about modifiers of cancer risk, when we think about an individual's risk for colorectal cancer, we've focused a lot on biology, we've focused a lot on genetics. There's more work going on to look at health behaviors and the environment, particular factors like the microbiome, the diet, chronic inflammation, the uptake of screening. Next slide, please. But what can we do now? And I would propose that we should start by making sure that we integrate colon cancer risk assessment into the routine health maintenance for all adults. All adults should be screened for symptoms of colorectal cancer, no matter what their age is, and all patients should have a conversation with their doctors about their family history, not only of colorectal cancer but also of polyps and other cancers, which can help us identify which families might be eligible for genetic evaluation that would provide an opportunity to intervene early and to start screening early that could prevent these cancers from developing. Next, we should continue to study factors relevant to colorectal cancer patients' diagnosis, and particularly study the tumors to see if we can identify associations that will inform strategies for cancer prevention. It's possible that dietary modifications may be able to decrease risk for colorectal cancer once we find out what things we need to do. Likewise, there may be other health behaviors that we can integrate now that will change those curves from sloping up to sloping down. And finally, doing a better job at stratifying individuals' risk will also help us identify who do we need to focus on earlier for screening. And then finally, we need to work harder to reduce disparities in healthcare delivery. We need to, as healthcare providers, we need to listen to our patients. And as patients, we need to make sure that our healthcare providers hear us and understand where we are coming from as patients. Increasing the uptake of colorectal cancer screening will help decrease incidence of colorectal cancer. And for years, some of the GI societies have advocated for earlier screening for individuals of African American ancestry. Now that colorectal cancer screening is starting at age 45, that is helpful, but it doesn't solve the problem because people like Candace will continue to develop their colorectal cancers at ages younger than 45, unless we can figure out how to identify them earlier. And frankly, standardizing colorectal cancer treatments, we know that people get treated differently, and we need to be able to change the way that care is delivered such that we are treating each patient with the best treatment that will be most effective against their cancer. Thank you very much for your attention. And I want to, I know we have some time to talk about questions, and I'd like to invite Dr. Sonia Kupfer to field some of the questions as well. Thank you.
Thank you so much. That was so informative, and I really, enjoyed listening to the slides and the data. And so I will ask a question or just talk about that. But I really find it very important that as what you said, is that although the age was lowered to 45, there's still an area of people that we're missing, right? So it's like, how do we, where do we, bang on the rooftops to get people to listen to, what we have to say about colorectal cancer younger than what I was at 35? Let's talk about the college age people. It's like, it's the awareness piece, right? So it's like, how do we get young people to take this seriously and to realize that this is something they should look out for? And how do we educate parents about this? How do we get that information that you just shared into the arms of parents, and so that they realize that this is something that's happening?
So, Candace, you always ask the easiest questions first. But I just wanted to thank Elena for such a fantastic overview. This is something we need to continue to learn more about, because we certainly want to not leave anyone behind as we're thinking about ways in which we can improve identification and, of course, treatment for early onset colorectal cancer. But to your point, Candace, I think that it's really important because 50% of young onset colorectal cancer is under the age of 45. So we have a chance to capture those people between 45 and 49. But like you're saying, those younger individuals, how are we going to educate people, both patients, families, but also providers, that colorectal cancer can happen under the age of 45, and it can happen in a 30-year-old or a 20-year-old. And I think part of this, and this is in general, is overcoming stigma and misconceptions. So because of you, I've had an opportunity to speak with a number of advocates and survivors, especially some African American survivors. And I've heard about just the stigma that comes along with thinking about anything having to do with the GI tract, with digestion, with going to the bathroom, having, stool, poop, whatever you want to call it. People don't want to talk about it. And then there's also the stigma about having a camera inserted into your large intestine that people have to overcome. So I think, just having the conversation, starting the conversation, and starting it as early as possible, because you're right that once younger people, it's normalized to talk about these sorts of things, either in the family or among your peer group. At least we can start to kind of attack this, but it has to happen among providers as well. I don't want to, sort of lose sight of that too, because saying that something is just due to hemorrhoids isn't acceptable anymore.
Wholeheartedly agree. We hear a lot of that within the cancer community over time, over the years that I've been an advocate, that it was always, well, this guy had a hemorrhoid, and then later, they're stage 4, and it turned out it wasn't hemorrhoid. It was colorectal cancer. And so those are disparities that we're dealing with, right? So that's part of the disparities, is not being listened to and not being heard. And then there's the other piece of PCPs not being up to date on screening guidelines. And that is such a huge component, or not hearing that it's time to be screened at the appropriate time. So how do we, and especially within in that community, the medical community of PCPs, how do we educate them that they need to be up to date on screening guidelines? How can we mandate that? I mean, I'm all about mandating, because I'm like, no one should lose their lives, or their quality of life, because, the person that they depended on to give them their medical information and direction was not up to date themselves. So now that we know that a USPSTF task force has joined ACS, how do we get that information into the hands of every PCP across America? How do we do that? And then how does that affect the quality of care? Because that contributes to the inequities that we see, right?
Yeah. Certainly multifactorial approaches are needed here. Us talking about it is very important, of course, and getting the word out to our local communities as well of PCPs. I think thinking about technology, so can we have our electronic health records pop-up reminders to take actually the thinking a little bit out of the provider's hands, and if you're reminded of it and then you have to sort of do something when you see that pop up. I think the other approach that we just don't do very well in the United States, there are pockets of this in California, for example, but having actual population health where you get a stool card in the mail at a certain age. We just don't have, as we very much know and has become painfully aware during this pandemic, is our public health system is really poor. And if we had more of a population health where we don't really depend on somebody showing up in even a PCP's office that, have that where that's opportunistic, we need to think population based. But those are, again, it has to happen on many levels. Elena, I don't know if you had some thoughts about how to reach our colleagues.
Thank you so much. I agree. This is a team effort. And this is one of those things that as medical providers, Dr. Kupfer and I work very hard to educate our gastrointestinal trainee specialists and primary care providers about the importance of when to think about colon cancer. But it's also something that I think empowering patients and families to be able to say, you know what, I'm going to go and I'm going to talk to my doctor about this, and I'm going to explain to them that there's colon cancer in my family, and we're going to have to make this a thing that we need to address. And I think that in that teamwork, that's how we're all going to advance. Because in the field of colorectal cancer genetic testing, we've seen that the people who get the testing, the squeaky wheel gets the grease. So if you ask the questions, then your doctor will have to respond to it, and he or she will have to learn about what you're asking in order to give you the right answer.
Awesome. And that is so true, because that was going to be my next question to you is about genetic testing, right? So we realize that genetic testing is just not happening. So how, and which contributes to the issue that we're having with early age onset. So, and a lot of times it's the insurance company, right, that is And to me, I always say insurance companies have way too much power as to who's able to get what. And so when you realize that that is a component, and then sometimes there's a fear of having genetic testing. So how do you encourage patients, or is there something that you talk about to discuss with patients about the importance of getting genetic testing and then sharing those results with family members?
Yeah, it's something we, of course, think about and are always trying to improve in the work that Dr. Stoffel and I do on a daily basis. I think on an individual basis, we try to understand what are some of the concerns and the fears. Obviously, insurance coverage is one issue. Although, the cost has come down significantly. There are ways in which to have payment plans. There are a number of ways in which we can assist with that. I think sometimes there are concerns about how this will affect insurability, and there are, what we talk about those barriers as well. I have found in the patient population I care for, often finding that champion in the family. So it happens to often be a mother in a family, I have to say, and that mother will go, high and low to get people from the family in for their screening and for their testing, and that can include genetic evaluation. So really trying to understand the dynamics in a given family. But there are challenges. One of the things early on when I started in this field, I was struck by, in my patients that I was caring for, many didn't know their father's history, for example. So I think differences in family structure play a role too in terms of knowledge of family history. So what we really need to be moving towards is kind of more universal approaches where we don't have to necessarily individualize based on all these different things. Of course, on a population level, we have to think about the cost of all these kinds of this testing. But I'll still say that even when you have things that are universal, someone still has to do something with that information that you obtain. So not just you have to do the test, but then you have to act on it. And sometimes disparities start to occur when there has to be an action taken. And that's what we've seen in a number of different areas. So how to close those gaps to make sure that care is equitable. It's not just doing the tests across the board. It's then doing something with that information. But doing the tests in the first place, if that's not happening, that's one place where we can start.
Awesome. Well, thank you both, Elena and Sonia. I hope that you will stick around, for some more questions and answers, because I see we have some right here in the chat, and we've kind of addressed them a little bit, but I'd like to bring them back, to the forefront at the Q&A at the end. So if you would just stay on with us and join us at the chat at the end of our two patients sharing their stories, that would be amazing. Thank you, thank you. So up next, everyone, thank you so much for staying in. I want to introduce patient advocate and survivor, Angela Caraway, who is, hi, Angela, come on and join us.
Hi.
She is the founder of and the executive director of the Caraway Foundation. So Angela will give us a brief story of her journey through cancer and why she started her foundation. Angela, welcome.
Thank you. Thank you so much, Candace, for having me. And I certainly appreciate the opportunity to have this platform to share my story again. I was 43 years old, and I never forget it because it was Martin Luther King weekend that I first noticed of 2015, I should say that, January 2015, that I noticed blood whenever I wiped, and I immediately thought it was a hemorrhoid. And because it was light, and I just like, maybe I have a hemorrhoid, and I was on vacation with some of my girlfriends, and I asked them, and they were like, "Girl, that's probably a hemorrhoid," and I was like, "Yeah." And so later on, a few months later, I saw blood again, and this time it was mixed in with my stool. And so I went to Google Medical University. That's what I called it. So I went to Google Medical University, typed it in, took a crash course on hemorrhoids, and kind of felt like that it was a hemorrhoid. And I got some preparation H, and I was like, where am I putting it? And then throughout those months, my primary care physician actually moved to Tennessee. So I had to find another primary care physician. At this point, it's July. I couldn't get into another primary care physician until October, which I was like, okay, cool. But then things started, and I started to see blood in my stool much more. So by the time I got to the new primary care physician, there was blood in my stool every time I pooped. And then I could not see a gastroenterologist until December. Well, let me say this. I couldn't see the one that she really wanted me to go to. But in the meantime, I went to another one. And that gastroenterologist said that I was too young for colon cancer, and it is probably a hemorrhoid. And since I had, there was a little area on my rectum that he figured that it was a hemorrhoid and gave me a prescription and kept it moving. So by the time I got to the gastroenterologist that my primary care physician wanted me to really see, it was December 23rd, 2015. So almost a year later, and he almost did not do a colonoscopy because he, one, said that the insurance company probably wouldn't pay for it because of my age. And then I shared with him my family history and that there were 6 different cancers at that point. And so he eventually went out of the room, came back in and said that he would give me a colonoscopy and for me to come back on December 29th. So on December 29th, 2015 is when I found out I had colorectal cancer. January 4th, I went and met the surgeon. January 12th, I had a foot of my colon removed because I had a tumor in the sigmoid area of my colon. And then and she removed 12 lymph nodes, and she found a large deposit of aggressive cancer cells within the lining of my colon. And I was diagnosed as stage 3 colorectal cancer and started February 23rd with 12 treatments of FOLFOX chemotherapy treatment.
Wow. So it sounds like you had a journey, to being diagnosed with this. And a lot of times we don't listen to our bodies, right? So, just okay, we saw something and it's okay. It's probably this, probably that. And, unfortunately it wound up being cancer, right? So how did that experience lead you to starting your foundation?
So I had already had the foundation, and I always had a love for people, and that was ingrained. That is something that is in my DNA. And what I did was, by being diagnosed, it's created a new program within the foundation called Village of Strength. And that program, I realized that there were more people in my home county, which is a rural area here in North Carolina, that needed support, that they did not have the support that the support groups that they needed. They met with church people, they spoke to family members, but they did not really have that support network. And so that's what I wanted to do. I teamed up with Atrium Health, that is located at Onset, which is in my hometown. And we started these support groups at the hospital and to talk about, and basically to provide an outlet for those who had dealt with or were dealing with some form of cancer or chronic disease.
I was about to ask you, okay, so to give people just a little bit idea of what the support that you're offering. That's amazing. Yeah. It is amazing because you're right. We need this support system, right? Because if you don't have anyone to talk to, just like me, I had no one that looked like me at the time, and so suicide was my option. Mm-hmm. You never know how many people are in despair at that moment, not just at life, and then you add other chronic conditions on top of it, right?
That's right. That's right.
So in addition to that, what else does because you gave me you told me some phenomenal things that you've done with your foundation just during, the time of COVID. Can you share a little bit about what you did?
Yeah, absolutely. So as we continue with the foundation and that program, Village of Strength, we basically focus a lot on our social media platform, with Facebook as well as Instagram. And so one of the things that we have been doing though since August is that we have been providing with a partnership with the USDA, those free produce boxes, and primarily wanted to make sure that those who are dealing with a chronic illness had fresh produce as part of their diet, because one of the things is that eating during this time is very important, and just having a really good diet with fresh produce was very important to me, and I know to others. So we continue to do that. Unfortunately, the program is ending this month, and but we were able to provide a lot of produce boxes every week. Normally it was anywhere from 1,000 to about 1,300. Some weeks was 2,600 boxes every week, to families and that were in need and those who had specific needs around chronic illnesses.
Awesome, awesome.
Yeah.
Thank you so much for sharing. Briefly, this, we can go on and on because there's so much work that you're doing. But unfortunately, we're limited. But I encourage you to be around so that if there's some questions after the call,
Absolutely,
that would be great. Thank you so much for
Thank you
with us. And up next, Jasmine. Welcome, Jasmine. Thank you so much for joining us. Hi. So Jasmine and I go way back. We are both advocates, and we've been advocates for the same platform, Colorectal Cancer Alliance and Fight CRC. So I am so excited to see you and to hear more about your story as you talk about your mom's journey through colorectal cancer and how you were her caretaker and how that led you to being an advocate that you are today.
Thank you so much, Candace. And hello, everyone. Thank you so much for having me. I'm really excited to share my story and kind of share, my experience through this whole process. As Candace mentioned, I was the primary caretaker of my mother, who at 42 years old was diagnosed with stage 4 colon cancer. And at the time, there were no resources. There was barely anybody that's Spanish at the hospitals. And so I had to be the translator. At 19, I had to break the news to my mom that she had a terminal illness. I had to translate what I could understand of me in terms, what the process and what they could do. At that point, unfortunately, there was nothing to do. It was a matter of time. And so it was so frustrating to, one, not have the resources to be able to help my mom. Like early on, she didn't have health insurance. And so she never went to the doctor when she was feeling ill. She really waited until the very end of anything that she was, any symptom that she was feeling, to go to the doctor, because they didn't have health insurance. And so that was frustrating. The other frustrating thing was that there was no one to really explain to her what had happened, what was going on with her body, what she could do to basically get through however many months. Because when they diagnosed her, it was so advanced. They said that the maximum amount of months that they would give her was 5 months. And I think it took her in 4. And so I quit my job at the time, and I became her full-time caregiver at home. They did do a colostomy bag. So I would go home every night after work and change out her colostomy bag, and I would bathe her, and I would do everything that I could possibly do to make her comfortable, especially because my mom was such an independent woman that it was really, really hard for her to just allow other people to take care of her. And so for years, I wanted to get involved. I wanted to do something to help, other families not go through what I went through. And so it just happened that Arizona State University, and they sent out this mass blast trying to find people that were bilingual to help with outreach to the Latino community. And I was like, this is a sign. This is my sign. This is a way to honor my mom's memory, to be able to go out into the community and help folks understand that, a lot of times it's having someone in your office speak the language that can kind of walk patients through, what that means, what the tests are going to be like, what to expect, when to expect the results, and how to actually be an advocate for yourself. And so I volunteered the first time for a health fair, and I've been volunteering with the Colorectal Cancer Alliance now for over 6 years. And I have also participated in Fight CRCs to help change policy so that, we can hopefully one day put an end to this disease and not have other families go through what we've gone through. And on a side note, my brother, who is 36, he just recently went to get a colonoscopy. Feeling well, they found 2 huge polyps already. He's 36 years old. Had I not been the advocate for our family, we wouldn't have, he wouldn't have known about these polyps that were quickly and aggressively growing, and they were precancerous. So it's really, I cannot state enough how important it is to really reach out and to really have advocates out there doing this type of work.
Awesome. Amazing. Well, I really want to share a really important point that you brought up, which is resources, right? And a lot of times when we as patients, we are looking for information. We're looking for services. We're looking for, just answers. It's all a part of resources, and it's patient navigation, which is something that we find out a lot that you don't hear a lot about in certain communities because they don't have a lot of patient navigators. And so that's now something that's over the last, few years, I can say in the last 10 years that I've been an advocate, that patient navigation is starting to gain more traction, than it has before, because I think a lot of us are saying, as patients and caregivers, where are the navigators? And when you hear that it's happening in certain areas and it's not happening somewhere else, you're like, well, why didn't I get it? And why don't you have it, right? So those are things that, that you brought up that I thought was very important, especially the importance of communication, especially in bilingual communities. Not having, and that's part of the disparities, not being able to communicate.
Absolutely. I just recently had my ex-husband had to go get a colonoscopy, and of course I'm the champion for everyone in the family. So I told him, I'll go with you, but with COVID made the situation really a lot more, put more barriers, because he wasn't, so he went in, and he's mainly Spanish speaking. The office that we went to, they didn't have anybody that was bilingual. And usually I would, go in there and I would translate, and I would help them out. But they weren't even allowing me to do that. And I was like, how are you going to have a patient go in and not fully understand what's going to happen, how, what the results are going to be like, talk to the doctor when the doctor is not bilingual and there's no one in the office. And so being the patient advocate that I am, of course, I finagled my way in, especially because I had been fully vaccinated, but other families don't have that. And so it's so critically important that if you want to reach our community, to make sure that you have someone in your office that can speak their language, in any language.
Awesome. Thank you. Well, I'd like to bring all the panelists back on because we have some questions in the chat. And I think there are a couple that are Sonia and Elena related. And then Joanne, there's a question for Angela. that asks if you have genetic testing and do you have a genetic syndrome?
Yeah, so I had the genetic test and I don't have the genetic syndrome. And what's crazy is that on my mother's side of the family, there's pancreatic, there's prostate, ovarian, breast, non-Hodgkin's lymphoma, stomach,
Wow.
lung, and for me, colon. And then on my father's side of the family, I had a cousin that also had colon cancer the same time frame I did. And my aunt, I'm not sure of a rare disease she had, but I was told that she may have caught something in the hospital, which was the old hospital, that maybe some fibers or something, but there's still some issues with that. So on my father's side, there was, besides myself, a cousin and my aunt. And then my mother's side, there's, 7 additional people besides myself. So, but I did take the test, and my cousin who had breast cancer, who was diagnosed at 18, and unfortunately she passed away when she turned 21. She and I both took the genetics test, and nothing.
Wow. So, what do you think about that, Sonia and Elena? You have anything to kind of weigh in on that? Is that common?
Yeah, I mean, there's certainly things we know, and there's many things we don't know, and genetics is one piece of it. So these syndromes that we know of, like Lynch syndrome, like Elena talked about, but there's also this connection between genes and the environment and environmental exposures. And so, we need better ways in which to identify people, and especially in these families with lots of cancer, especially at younger ages. But I think even just knowing that information, if there are ways in which we can, just based on family history, screen people earlier. So, for example, among individuals with early onset colorectal cancer, a quarter of them would have been screened at age 40 just based on their family history, putting, hereditary syndromes aside. So we have opportunities to use a 10-year rule where we go 10 years before the youngest person in the family. And I think, when we don't have a syndrome that we know of, where we know when to start screening, we need to understand the family history and use it.
So if someone was, so this is, so there's a question. So if someone was screened, let's say, I think, Angela, you said you were diagnosed in 2015?
Yes, 2015, and I was 43.
2015. So how soon after her having a genetic test, how soon afterwards should she take another genetic test? Because we know genes are always being discovered, right? So when would you recommend her taking another genetic test?
So I can take an answer to that. So the question was, how comprehensive was the test? Did the test look at just colon cancer genes, or did it look at additional genes that are associated with other common hereditary cancer syndromes?
It did.
And so that's the thing, is that we do learn more and more as years go on. And as Dr. Kupfer and I know, for years now, we've been looking for new, really strong colon cancer genes. And we've actually found the ones that seem to be important were actually detected back in 2015 or earlier.
Mm-hmm.
So in the past few years, we haven't found a lot of additional genes. The question is whether, as Sonia alluded to, whether there are combinations of maybe some other minor genetic factors that we haven't identified yet, in combination with environmental exposures. And so that's where a lot of the work is going into, looking at the tumor characteristics, to see if the tumors that we see in particular families or in particular geographic areas have certain features that might suggest a common kind of environmental exposure.
Awesome. Thank you. So there's a question here by Benny Johnson. It says, how do we encourage PCPs to start screening at age 45? I feel that this is still, is still met with such huge resistance, since USPSTF has not given the final recommendation, but they have given a grade A and B, right? So I think that's just forthcoming. But just like as we were discussing earlier, how can we get them to jump on board? Because I know for me, I've been having a challenge just to get people to change even writing it down from 50 to 45. So even though we haven't, hey, it's coming. So why not put it as 45 so that you don't have to backtrack and do it later?
Maybe I can just comment on the fact that for some people, insurance companies won't pay for the testing starting at 45 until it's a final recommendation. So just understanding that having insurance coverage for a test is critically important. But you don't have to wait much longer. Next week is when the final recommendation will be coming out. So at that point, it should be covered by all insurance. That's what happens with the USPSTF. But just to remember that at 45, there are different tests. So, the test that gets done is the best one for colorectal cancer screening. And, that should be discussed on an individual basis. But we don't have to wait much longer. It's coming.
Awesome. Jasmine, I want to circle back to you because I'm in a health equity piece with this, and and what you shared was so heartbreaking about your mom and not having the resources and the language barriers that that it taken even during COVID. COVID really showed the world how our healthcare system is really lacking and the healthcare disparities, right? So with that being said, and your mom didn't have any healthcare insurance, that's a lot. That's a lot for a 19-year-old to carry. So, my heart goes out to you and, for what you've done and then what you do. What is it that you would like to see changed now that you're an advocate and what you've experienced, versus what you haven't seen, from the time that you saw your mother diagnosed at 19 to now? What is it that you'd like to see change that you haven't seen change within the CRC space?
I think honestly is still, we have doctors' offices that do not have people that can speak the language. There are so many resources. There's services that you can call into so that service can translate in any language. And so I think that piece has still not made it to where it needs to be. It's so important to have materials in the language of the person that you're seeing, treating, diagnosing. It's important when you do outreach events to know your community, have someone that knows the community to do outreach. We actually had a hugely successful event for the Latino community. We had to turn away people from the screening process because we had such a huge turnout. So it doesn't mean that our communities are not interested or that they don't want to do this. They want to do it. If they understand what you're asking them, if they understand how valuable the information is, and it's presented in a mode that is specifically targeted for them.
So you think it's important understanding the culture, right?
Yes, absolutely.
Yes. And then understanding taboos and religious barriers are important to the discussion, right? So can you speak just quickly about genetic testing, in the Latin community? How is genetic testing viewed? Because I know that in some communities it's viewed as intrusive, but this is a really good opportunity to explain to the viewing audience how certain communities view genetic testing. Oh, can you hear me?
Yes. So I think that again, I think it's lack of information. I think that they know that this test is very intrusive, but when someone actually takes the time to explain to them what the process is, especially like someone that has gone through the process, like I get mine every 3 years, so I can tell them exactly what the process is, how it works, what it feels like, and actually, talk to them in their language, understand their culture. It makes a huge difference, and they're willing to. Like I said, it's not that they don't want to. It's just lack of information, lack of understanding, and there is some something to do with religion, but that's why, again, when you're trying to do an outreach program, you reach out to the local churches, you get their buy-in, you get volunteers from those churches to be able to help. We did that. We partnered with the Phoenix Diocese to make sure that, you know, our community was, you know, comfortable. And we did like a little, during one of their masses, you know, so there's so many different ways to outreach to the communities. But it, again, like Candace said, it's understanding the culture and understanding what the method of communication and just having things in their own language.
Absolutely. Thank you so much. One last question, because I want to talk about the gut microbiome, because that's something that's coming up, right? That's something that's being studied, and I'm so proud to be a part of a study. So what are your thoughts? What are your thoughts about this? Are the findings of the gut microbiome, are you finding that there may be a significant, you know, like eye-opening, like, aha, here's the challenge to the, you know, the under, you know, 45 population, the early age onset, this is what's causing, you know, the issues of you know, colorectal cancer in younger people. And then my other question is, I just found out that there's a difference of gut microbiome in babies that are born C-section versus born vaginally. And my question has been, has anyone explored that difference as a possibility of that affecting early age CRC?
So Candace, again, you ask the easiest questions to end now. You know, we're just at the beginning. This is the tip of the iceberg, and we're just even now able to study the gut microbiome. We weren't even able to do that 10 years ago. So what we know right now is just, we know what bugs may or may not be there. Now the hard work comes in trying to understand how those could actually increase risk of not just colorectal cancer in younger individuals, but colorectal cancer overall, and a whole host of other disease processes. Of course, you know, we think that there is a role, but what that role is and how we can intercede, how we can change that, especially if it's something that happened when you were born, because like you said, there are differences based on the mode of birth. So much to be studied, so much more to learn. And thank you for participating in research, because that's huge. We need to have diverse populations in research studies so that we can generalize our findings, because that's often a problem, is we study it in one population and then we generalize it to everyone. And that's not the way we should do things. So.
Well, you all have been amazing. I thank you so much for being on this panel and sharing your stories and sharing the work that you're doing, which is amazing. And I can't wait to see what happens as we continue this work. And I'm just so proud to have joined you all on this panel. I hope that you have a wonderful Sunday and enjoy the rest of this day. And thank you all for joining us. And if you have any more questions, even after our panel is over, feel free to send them on and send them to us, and we'll be more than happy to discuss. Thank you all. Have an awesome afternoon.
Thank you. Thank you.